going to be a postpartum assessment on a newborn baby. So I'm going to receive the baby from the doctor or the midwife or whoever delivered the baby. Take the baby in warm blankets, and then I can either give baby to mom and do skin to skin, or put baby on a warmer with warm blankets as well. So we're going to start our assessment by just looking at the overall appearance of the baby, making sure that the baby is crying, that the skin looks good, coloration is good, baby doesn't appear jaundice or cyanotic. So at 1 and 5 minutes, I'm going to do an APGAR test on the child. So APGAR would start with, again, looking at the appearance of the baby, checking the baby over, making sure nothing looks abnormal, making sure the baby is symmetrical in stature. I'm then going to check the baby's pulse. So I'm going to listen to the baby's pulse for a full 60 seconds at the apex of the heart, ensuring that the baby's pulse is over 100 beats per minute. If the baby's pulse is not over 100 beats per minute, we would then carry on to provide resuscitation measures for the child. So after I've checked the pulse and ensured that it's over 100 beats per minute, I'm going to look at the grimace of the baby, which is the baby's affect and how it's responding to my touch. So I want to make sure that as I touch the baby, it's making a facial expression, it's crying, and at what level is it having a reaction to my touch. I'm then going to look at the baby's activity, make sure that the baby's moving. In most cases, they're going to have their legs and arms crunched up. If I kind of pull them away from the baby will pull back on me. And then I'm going to look at the respirations of the baby, making sure that there's no increased work of breathing. I'm not seeing any retractions, substernal or suprasternally. I'm not noticing that the baby is grunting at all or having any nasal flaring. So as far as the APGAR test is, this baby is healthy with an APGAR test of 10 for minutes 1 and 5. And then I'm going to go into the head-to-toe assessment on the child. I'm going to start at the head, making sure that everything is symmetrical. There's no lumps or bumps or abnormalities of the head. Making sure that I'm checking the anterior and the posterior fontanelles. They should be flat and soft. We don't want them bulging or sunken in for fear of dehydration or intracranial pressure. I'm going to make sure that I'm just checking the suture lines, see if they're overriding or if they're separated, and just making sure everything feels all right on the baby's head. I'm going to move down to the eyes of the baby, making sure that they're again symmetrical and functioning properly. Looking at the ears of the child, making sure that there's no deformities on the exterior of the ear. And looking at how the ears and the eyes align. If the ears are lower than the eyes, it could mean that the baby has a genetic disease or some type of syndrome. I'm going to move to the nose of the baby, making sure that each nair is patent by occluding one and then occluding the other and seeing how the baby responds, because babies are nose breathers. I'm also going to look at the symmetry and structure of the nose to ensure that it is okay. I will move down to the mouth of the baby, just looking at the appearance of the mouth and the symmetry as well. With a gloved, clean finger, I would put my finger in the baby's mouth, feeling for the hard and the soft palate on the roof of the baby's mouth, ensuring that there's no sign of cleft lip or cleft palate. I would then move down to the clavicle of the baby, feeling for any fractures that may have occurred during labor. And then I'm going to just look at the neck of the baby, ensuring that it's got proper range of motion and that there's no webbing in the neck. I would then move down to the chest of the baby. Again, I'm going to look for symmetry and structure, ensuring that it looks as it should. I'm going to listen to lung sounds of the baby. I'm going to listen to lung sounds bilaterally as well as anteriorly and posteriorly. Ensuring that the baby's rate of breathing is normal, and it is. So sometimes when I'm listening for breathing in a newborn, I could hear crackles, which would be a normal finding in the first day or two. Excuse me. And then I'm going to move on to listening to the heart rate of the baby again. So I'm listening again to get an apical pulse for 60 seconds. And I'm also looking to hear if I can hear any murmurs that the child might have, making sure that I get a second set of ears if I do find one. And if we do find one, knowing that it could be a normal finding in the first couple days of birth. I'm going to check pulses at this time, so I'm going to check the brachial pulses and the femoral pulses bilaterally. I'm also going to check pulses on either side of the baby, so I'm going to do the arm and the leg at the same time and see how those correlate with one another. If there is a large difference between them, that could mean that there is a heart defect that the child might have. And again, while I'm looking at the chest, I'm looking for any retractions that might be occurring due to an increased work of breathing. I'm going to move down now to the abdomen of the child. I'm going to palpate, just make sure that it feels normal. If I feel like it's distended at all, then I would take a girth measurement and just make sure that we're tracking that. Sometimes the stomach is filled with fluid after birth, so that could be the cause. If we have to, we could also insert an NG tube in to release some of that fluid if we feel like it's excessive. I'm then going to palpate for the spleen and the liver. I shouldn't really feel either of them unless they are enlarged, and then I would inform somebody of that. I'm going to look at the umbilicus, just look at the color, the appearance of it, make sure it looks good and healthy. I'm going to assess whether there is 2 arteries and 1 vein in the umbilicus. I'm going to listen to bowel sounds of the baby and just make sure that I'm aware, as well as the mom is aware, that we want to know when the first bowel movement is, and that there's no issues with voiding, that the baby is urinating, and again, they could have only 1 bowel movement or void within the first day or so. So we just want to make sure we're keeping track of that. I'm then going to move on to the musculoskeletal system of the child. So I'm going to just look at the overall movements of the child, check its fingers, make sure that there's no extras, that nothing's webbed. I'll move down to his feet, again making sure that there's the amount of digits that there should be, that there's no clubbing or curvature in the feet, and that there's no extra digits on the toes. I would then, while I'm down at the feet, make sure that the legs are symmetrical to one another as far as length and size, as well as the arms. I'm going to look at those, and then I'm going to check for hip clicks, which could indicate that the baby may have a dislocation of the hip. And then I'm going to make sure that I turn the baby over and evaluate his spine and the curvature of the spine, ensuring that it's symmetrical and straight, that there's no deformations, and I'm just going to check the base of the spine down by the coccyx to ensure that there's no dimpling or hair tufts that might be present, as that could be a sign of a neural tube defect. I am then going to move on to the genitalia of the baby, so just inspecting it, making sure some babies can be born ambiguous, so making sure whether it's male or female genitalia, looking at the appearance. So I have a female child here. I'm going to just make sure I'm looking at the vaginal opening. The labia major may be a little bit swollen from birth. I may see some discharge that's white or pinkish, which is normal because of the hormones from mom leaving the baby. And I just want to make sure that the baby is voiding correctly and voiding in a symmetrical stream. If I had a male child, I would make sure that I'm looking at, again, the symmetry of the urethral opening at the meatus, making sure that it's not under or above where it should be. And I'm going to make sure that I'm checking for the testes, that they've descended in a term baby. They should be descended. If the baby is preterm, I'm going to check the inguinal canal and make sure that it's there, it feels normal, and let them know that it should descend as the baby grows. And as I'm there, I'm also going to check for any inguinal hernias. While I'm looking at the genitalia of the baby, I'm going to check the anus of the child, ensuring that it's patent, and then I can do that by inserting a rectal thermometer and making sure that I get the retraction or the anal wink, so that everything is in working order. I am then going to go and do a neuro test on the baby, so that's checking baby's reflexes. I did check when I stuck the finger in the mouth to check for the hard and soft palate that the baby had a sucking reflex. I would then go on to the rooting reflex, so rubbing the side of the baby's cheek, that baby should turn its head towards that side, allowing it to look for the nipple and a food source. I'm then going to check palmar and plantar reflexes on the baby, so putting my hand in their palm or under their toes, could have their fingers or toes curl over my finger. I'll check the Babinski reflex, which is just stroking the bottom of the baby's foot, and its toes will flare. I'm going to check the baby's Moro reflex, which is a startle reflex. I can do that by just lifting the baby's arms up and letting them fall to its side, and he'll jump a little bit. And I'm going to check the trunk incurvation reflex, which is if I have the baby on its stomach and I rub one side of its back, it will turn its spine towards that side. So as far as neuro goes, I think that's all the reflexes I'll check. The baby checks off fine, and then I'm going to do some measurements. So I'm going to measure the baby's head circumference by using a tape measure. I'm going to go right above the baby's ears along the forehead and check that. I'm going to check chest circumference, so going right along the nipple line around the baby, and then I'm going to check length of the baby, so right from the tip of the head all the way to the toe. And that would be the end of my postnatal assessment.